Friends, welcome to my workplace for hands-on Phaco and SICS training. Let us observe this totally unedited surgery. This is an intumescent cataract. This is the main incision with a 2.8 millimeter steel keratome. The incision is on the posterior aspect of the limbus. This is a side port on the left side of the main incision, about 3 clock hours away. And now an air bubble is injected to fill up the anterior chamber. Trypan blue dye is then applied underneath this air bubble over the anterior capsule. This is a bit of adrenaline to maintain dilatation of the pupil during emulsification of the cataract. Excess dye is washed out with BSS with the help of a Simcoe cannula, and now the anterior chamber is filled up with 2% hydroxypropyl methyl cellulose. I do not use sodium hyaluronate, but if you find that it gives more control, it means sodium hyaluronate gives more control in your hands, you can use it. So this is a small rhexis first by the ureter itself. I don't attempt to do a large rhexis at on-go in such cases in intumescent cataracts. And now through this opening I remove some cortex from all around, not just from one area. I squeeze the cortex from periphery, it comes near the center, and I aspirate the cortex. I try to rotate the nucleus by the Simcoe cannula itself. Lot of cortex from posterior aspect comes along the equator anteriorly, and I aspirate that also. After aspiration of a significant amount of cortex, the intralenticular pressure is reduced to such an extent that chance of rhexis run out is almost zero. See this one. I am spending a lot of time in removing the cortex, maybe about 1 minute. And now the anterior chamber is filled up again with 2% SPMC. Now I am planning to enlarge this rhexis. How to do this? Take a Vanna scissor, make a slant cut, make an oblique cut, not a radial cut at some point. I am a right-handed person. I have made the cut at around 7 o'clock. If you are left-handed, you will make the cut at around 5 o'clock. And doing the rhexis. The rhexis has been enlarged to optimum size, and we can see that the cataract is not soft. Nuclear sclerosis is about grade 4, it is a brown nucleus. And in such cases, when the nucleus is brown, my technique is submarine chop technique. The main wound has been enlarged to about 3 millimeter, so that leakage of fluid occurs around the phaco needle and the wound remains cool. This is an way to prevent wound burn. And this is the submarine chop technique. The nucleus has been divided into 2 heminuclei at on-go. Then each heminucleus is being subdivided into fragments. Ultrasonic energy is set at 80%. Flow rate is 48 ml per minute. Vacuum is 480 millimeter of mercury. During emulsification of the last piece, I reduce the parameters. Ultrasound is 70%, flow rate 40, vacuum 400. This is Oatley Cataracts 3 phaco machine. Nucleus has been managed. Now some cortex is remaining. I inject a bit of visco. This is using XOI to center the. This is a little bit of visco, and now I am going to use 23G Simcoe cannula and remove the cortex. I use a 10 cc glass syringe to aspirate the cortex. Cortex removal is done. Now in this case, the intraocular lens selected is a hydrophobic lens from Rayner, the company who brought intraocular lens in the world first time. Harold Ridley and Rayner, they are the pioneer of intraocular lens surgery. And now what has happened in this case is the lens has tumbled, or the lens has been loaded. No, this is a preloaded lens, so the lens has somehow tumbled, and I have to flip the lens so that orientation becomes okay. And now to orient the lens, I asked for visco. This is visco going through the side port, and now I take two hooks. One hook goes through the side port, another through the main port, and the lens is flipped in this way. And the haptics are placed in the capsular bag. Rayner lenses are beautiful, high quality lenses. Surprised that a company is doing such great work since 1949. Almost 75 years. And now this is the final lavage of the anterior chamber. Not final lavage, initial lavage to remove visco. First I use the Simcoe cannula, then bimanual irrigation aspiration, and then Simcoe again, and then conclude the case. So always do double rhexis in intumescent cataracts. When you don't use sodium hyaluronate or sodium hyaluronate and chondroitin sulfate combination, when you manage only with SPMC and do a small rhexis and remove the cortex by Simcoe cannula, that is Mohanta's technique. Momirex, Mohanta's mini rhexis, is done only with the help of SPMC. But don't try unless you are experienced. First, try with sodium hyaluronate and chondroitin sulfate combination, and once your hands are trained, then you can try only with SPMC. Why only with SPMC? Because there are places where patients can't afford high cost accessories. This is the final stave formation of the anterior chamber, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion, and great surgical competence.